Yeah, good evening, dear my professional colleagues. I am Dr. Sepuri Krishna Mohan. I am a senior endocrinologist at my own center, Sepuri Diabetes and Endocrine Center, Karnool. So, thanks a lot, Mr. Chaitanya from Teddy Labs for giving a kind introduction. And yeah, thank you so much. And today we are going to talk about the role of the SGLT2 inhibitors in the cardio-renal and the metabolic, the CRM spectrum. So, per se, we are going to talk about the role of Dapagliflozin today. So, as of now, we have got three US FDA approved gliflozins. These SGLT2 inhibitors are called gliflozins. So we have got the canagliflozin, which was approved by US FDA in the year 2013, and the empagliflozin in the early period of 2014, and the dapagliflozin in the latter part of 2014 actually. So we have got the three approved US FDA approved molecules in our country, but we have got several other molecules which are not present, not available in our country, but they are available in the Western scenario. That is either the United States of America or the European Union or the United Kingdom or this particular the advanced countries like Canada and all. So the other molecules apart from this particular anagliflozin and the dapagliflozin and the empagliflozin, there is one molecule called ertugliflozin, and there is one more molecule which has got the dual action, that is SGLT2 inhibition as well as the SGLT1 inhibition. That is the dual mechanism which has got a little bit more efficacy when compared to this. So because that is blocking the 1 and 2 SGLT2 receptors, which is called the sotagliflozin. And the others available are the bepragliflozin and the pipeline. We have got one more gliflozin. This is the bexagliflozin, bepragliflozin is available, and the pragliflozin is in the pipeline. So these are all the molecules which come under the SGLT2 inhibitors, otherwise called the gliflozins. So today we are going to talk about the dapagliflozin across the cardiometabolic renal spectrum. With this brief introduction, we will get into the session. So this is the disclaimer. So the table of content, the epidemiology of type 2 diabetes in India, and the guideline based management of type 2 diabetes mellitus, and the beneficial effects of SGLT2 inhibitors in type 2 diabetes mellitus, and per se dapagliflozin, the recent clinical update in type 2 diabetes mellitus, and the pipeline studies in type 2 diabetes mellitus, and the last is the take home message, that is the summary. So this topic is divided into these subtopics. And coming to this particular slide, the type 2 diabetes mellitus, an overwhelming epidemic. See, earlier we used to write this Roman 2, but now it is only simple English, the normal 1 to what we write. Even for T1DM and T2DM, it is which is in the brackets is the Act 1. So the global projections of the type 2 diabetes by 2030, 578 million people, that is 10% of the global population, will suffer from type 2 diabetes mellitus. By 2045, the projections all over the globe will be 700 million people and even more It's like an epidemic actually, though it's a non the NCDs, that is what we call the non-communicable diseases. So almost 10.9, that is 11% of the global population would be suffering from type 2 diabetes by 2045. This is the projection that is by the International Diabetes Federation, the Diabetes Atlas. And the Indian perspective, and according to the ICMR INDIAB, the National Cross-Sectional Study, between October 18, 2008 and December 17, 2020, so 11.4% have got diabetes, 15.3% have got pre-diabetes, and 35.5% have got hypertension, and 28.6% they have got generalized obesity, and 39.5% have got abdominal obesity, which is very, very alarming, and which is increasing like anything, abnormal proportions, the abdominal obesity. See, abdominal obesity is called the typical Indian tummy, which is the culprit for this particular the heart attacks, the cardiovascular disease actually. So 81.2% they do suffer from the dyslipidemia. Coming to the next slide, the profile of the Indian diabetic cohort, the results from the different Indian studies, the Asian Indian phenotype. So, how is this particular Indian type 2 diabetes is different from the rest of the world, that is maybe the Caucasians especially. The mean HbA1c level was uncontrolled as 7.24 plus or minus 1.80. HbA1c was marginally higher in patients with type 2 diabetes. The duration of less than 5 years as compared to those with type 2 diabetes mellitus, a duration of more than 5 years. And significantly associated with the age, the smokeless tobacco use, and the hypertension and the obesity. And the worst part is the diabetes, the type 2 diabetes occurring in Indian population at least 10 to 15 years earlier when compared to the Caucasians. And the presence of dyslipidemia is more than 80%. We have seen in the last slide, it is more than 82% it seems. And hypertension is more than one third, nearly two thirds of the American College of Cardiology bar American Heart Association criteria are used. And obesity is nearly a third of the population, and low HDL cholesterol and high triglycerides accounted for most of the dyslipidemia. The low adiponectin concentrations and the increased visceral fat and the increased waist circumference and the increased insulin resistance are the determinators which differ from the type 2 diabetes when seen in the Caucasians. And the most important point is the lipoprotein little a and ApoB are the major culprits. Unfortunately, we don't have treatment other than giving for lipoprotein little a. We can manage with the 75 milligram of aspirin. Statins will not control this particular the lipoprotein little a actually. Even the ezetimibe cannot control even the PCSK9 inhibitors like inclisiran and all, the avelumab, they also fail to control meticulously the lipoprotein little a and the ApoB. So the SGLT2 inhibitors in the Indian scenario. Indians have distinct clinical and biochemical deformities which make them the so-called the Asian Indian phenotype. And in a way, it's a happy thing that the DPP4 inhibition and the SGLT2 inhibition is very, very effective in Indian population and the Asian population also when compared to the Caucasians. So the reductions in the fasting plasma glucose and the 2-hour post glucose and the HbA1c are much better when compared to the Caucasians as far as the DPP4 inhibitors, that is gliptins, and the SGLT2 inhibitors, that is gliflozins, are concerned. This is one the plus point we have. And the challenges with Indian patients on the left hand side, and the relevant SGLT2 inhibitor features on the right hand side. The higher abdominal adiposity and the visceral fat at any given body mass index, and the decreased body weight, more visceral fat mass loss than the subcutaneous fat loss, and the higher waist circumference and the waist to hip ratio. Whereas with SGLT2 inhibitors, we see the reduced waist circumference as that leads to a significant weight loss apart from the lowering the glucose and lowering the blood pressure, apart from this particular the cardiovascular and the kidney and the liver benefits. So low levels of adipokine and high plasma leptin increases concentrations of triglycerides, leads to this reduced both triglycerides and leptin where the patient is on the SGLT2 inhibitors, and low rate of the glucose disposal, which increases the rate of glucose disposal, and the impaired insulin secretion and increased insulin resistance, and they improve the beta cell function and the decreased insulin resistance. See, in Indians and the especially the Southeast Asians, that is called the Indian continent, the Indian subcontinent, the major problem is the insulin resistance, not the insulinopenia. I don't mean to say that there is no insulinopenia at all, but more than insulinopenia, we have got insulin resistant. The insulin resistance actually. So the cardioprotective effects of the SGLT2 inhibitors and the mechanisms, the SGLT2 inhibitors, they act on the heart by lowering the blood pressure and the natriuretic diuresis. The specific property of this SGLT2 inhibitors, and on the other side the ketone body metabolism and elevation of the hemoglobin and hematocrit level, the suppression of this sympathetic nerve activity, and the efficacy on the erythropoietin. It increases the erythropoietin, this particular SGLT2 inhibitors, and the inhibition of the NHE and the activation of the eNOS. These are the mechanisms of the SGLT2 inhibitors whereby it protects the heart. The SGLT2 inhibitors are the promising therapeutic agent for the patients suffering from type 2 diabetes mellitus. You can see this is a very busy slide. So the essence is the SGLT2 inhibitors demonstrated a significant cardiorenal, metabolic and the hepatic protection, and the SGLT2 in the inhibitors in type 2 diabetes, that is with atherosclerotic cardiovascular disease or high cardiovascular disease risk, there is 14% reduction in the cardiovascular mortality and 13% reduction in any cause mortality, that is all cause mortality, and 23% reduction in the cardiovascular mortality or the hospitalization for the heart failure, and 30% reduction in the hospitalization due to heart failure, and 10% reduction in the non-fatal MI, and 12% reduction for the MACE, and the 33% reduction in the kidney composite outcomes. So coming to the comparison of effectiveness among the different sodium glucose transporter 2 inhibitors, that is SGLT2 inhibitors, according to the underlying conditions, a network meta-analysis of the randomized control trials, like the left hand side, the figure shows the network diagram of the included trials. The line widths are the proportional to the number of trials comparing with the corresponding pair of treatments actually. So you can see the placebo 44,000 change patients, and the sotagliflozin 6,000 change patients, and the ganagliflozin with 8,000 change, and respectively the dapagliflozin includes the largest number, that is 18,000 change patients, and the empagliflozin 13,000 change, and the etigliflozin that included 5,500 patients actually. So the inferences drawn from this particular all these studies, the difference is reducing cardiovascular and kidney outcomes, as well as the safety profiles across the SGLT2 inhibitors were comparable irrespective of the diabetes status. And the SGLT2 versus the GLP-1 receptor agonists. So you know the GLP-1 receptor agonists, they are the injectable anti-hyperglycemic agents, starting from the exenatide to this liraglutide, and the oral semaglutide, which is available in our country, the Rybelsus, the 3 milligram and the 7 milligram, and even the 14 milligram also. And the injectable once a week semaglutide, even you got even the Byetta is also now extended release, but the Byetta, that is the once a week exenatide, did not show any cardiovascular benefits, whereas the leader study with the liraglutide has shown the maximum cardiovascular benefits, and also with this oral semaglutide, that is the brand name is Rybelsus, Novo Nordisk. Even this particular liraglutide is also from Novo Nordisk, whereas this particular the exenatide is from Eli Lilly. And again there is lixisenatide, and there is one more the latest molecule from Eli Lilly, that is this particular which has got the dual terzepatide, that is with a dual mode of action on the GIP and the GLP-1 receptor agonist. They are very good at reducing the weight, as well as the reducing the risk of the atherosclerotic cardiovascular disease. See, per se, I need to tell you the basics where this particular the SGLT2 inhibitors or the GLP-1 receptors are indicated, is that both of the things, if at all you feel you need to start, especially the SGLT2 inhibitors, you need to start very early in the course of the type 2 diabetes disease process, because if you don't start the SGLT2 inhibitors early in the course of type 2 diabetes mellitus, you will not be able to achieve the renal and the hepatic benefits. If you start late in the course of that, after the patient suffers from 30 years of diabetes, you start this particular the SGLT2 inhibitors. It is a mere glucose lowering agent, and maybe to some extent it may reduce 2 to 3 kilos of weight. Beyond that, it is not going to exert the desired the cardiovascular, that is the 3-point MACE, and the heart failure, and the hospitalization for the heart failure, and the kidney benefits, and also the hepatic benefits in case of the NAFLD and the NASH. And now the nomenclature is changed to the MASLD, that is metabolically defective associated steato liver disease. So the indirect comparisons with the existing evidence and the inference is that In the population of people with type 2 diabetes mellitus, SGLT2 inhibitors, they were superior to GLP-1 receptor agonist in reducing the renal composite endpoints and the hospitalization for the heart failure. The first international body that mentioned the role of the SGLT2 inhibitors and the GLP-1 receptor agonists is the European Society of the Cardiology way back in 2019 itself. Before any international body gave the norms, the European Society of Cardiology (ESC) 2019, the guidelines itself, it said you find a case of the drug naive patients, that is newly detected type 2 diabetes mellitus, who are at risk of developing atherosclerotic cardiovascular disease, or are developed already the case of the heart failure or the atherosclerotic cardiovascular disease with the 3-point MACE or 4-point MACE or 5-point MACE. And even without initiation of the metformin, you can straight away initiate the SGLT2 inhibitors as first line of drug of choice. In particular, the cases what I have specified, the two categories, that is at risk of atherosclerotic cardiovascular disease or the heart failure, or the already established case of atherosclerotic cardiovascular disease and the heart failure or the hospitalization for the heart failure. So what it said is, the first drug of choice is all the time the SGLT2 inhibitor. Unless otherwise it is contraindicated, you need to start even before starting the metformin. Even you can ignore that and you can start. And if it is the predominant atherosclerotic cardiovascular disease where there is no heart failure and there is no risk for heart failure, the GLP-1 receptor agonists are the best drugs of choice to start with. Or the best is what it said is, combine SGLT2 with the GLP-1 receptor agonist if possible, and if the patient can afford to go for that, it is the best combination. So if you add metformin to this particular this SGLT2 inhibitors and the GLP-1 receptor agonist, that will be the best combination on the earth actually. So later on, the European Association for the Study of Diabetes, that is the EASD, has joined its hands with the European Society of Cardiology, and in the late 2019, they gave a joint consensus. The ESC bar EASD 2019 joint consensus said the same thing, and later on, the European Society of Hypertension, and later on the American College of Cardiology and the American Heart Association and the Heart Failure Association of the America, that is that also gave the same type of recommendations, but they said the first drug should be metformin, then you can add along with metformin immediately. You don't need to wait for any other option. With metformin, if this predominates or the patient is at risk of developing or already developed, you can add at a time the metformin and the SGLT2 inhibitors, and the patient can afford to go for this GLP-1 receptor agonist, because though it's a weekly once injection, subcutaneous injection, but it's a little bit costly when compared to the other things. Like the one more this thing I forgot to mention is the dulaglutide, and albiglutide is virtually useless. Dulaglutide has proven to be a better molecule when compared to the albiglutide, and the exenatide, barring exenatide and this albiglutide, the dulaglutide and the liraglutide and the oral and the injectable semaglutide and this particular tirzepatide, these are the best GLP-1 receptor agonists, and there is a head-to-head fight in between the injectable, once a week injectable, the semaglutide and the tirzepatide actually. So some studies have shown better efficacy with tirzepatide, and some have shown, see, these studies are a little bit biased because they are funded by these companies who have originally it's a research molecule of that particular company, give some edge to that particular molecule. Though we are running in the evidence-based medicine era, but still use your common sense and just don't be just very blind to these studies. They are little bit biased. And this is the treatment algorithm of the American Diabetes Association 2024, the guideline directed management of type 2 diabetes mellitus. And you can see that the SGLT2 inhibitors for glycemic management and the comprehensive cardiovascular risk reduction, independent of A1C, and in consideration of the person specific factors. And the Indian consensus, the SGLT2 inhibitor should be preferred in most patients with atherosclerotic cardiovascular disease, and the first choice in heart failure and the CKD. But there is a limit for everything. See, you want to start this particular SGLT2 inhibitors in CKD, you need to go by EGFR. See, if you are initiating SGLT2 inhibitors, the cutoff point of SGLT2 inhibitor where you cannot initiate is around or less than 30. You cannot initiate an SGLT2 inhibitors. Though the existing already the users who are using this can be continued according to the latest guidelines until the 20 ml per minute of EGFR, but a new patient can never be started like metformin. Earlier we used to have the recommendations in a different way. Long ago we used to have before 2019 the latest recommendations regarding metformin have emerged. Before that the cutoff point was 45 ml per minute, and now you can use it until the EGFR of around or more than 30 ml per minute. See, like that there is a cutoff point for SGLT2 inhibitors, and later on I'll tell you all the time the companies will tell you the pros only, not the cons. They tell you the greatest advantages, and it has to be used in this condition, it has to be used in this that condition, this condition, but they'll never tell you where it should not be used. You have to be very cautious with all the molecules, especially the SGLT2 inhibitors. So though the slides don't contain that particular material, I'll tell you where to use, where not to use. So here is a case presentation. Actually, a known case of type 2 diabetes mellitus came with chief complaints of giddiness and weight gain by 3 kilos. It's a known case of hypertension. On examination, the findings are the A1C is 8.5%, fasting plasma glucose is 165 milligram per deciliter, and the weight is 76, and the blood pressure is 142 by 94 milligrams of mercury. So it is high, and you should be well versed with the latest recommendations of the European Society of the Cardiology and the European Society of Hypertension, which has released the guidelines 3-4 months prior to this November actually. So somewhere around June, July it has released. The 2024 guidelines have come into vogue. You need to be meticulous with the cutoff points and where you need to start a medicine. That and all is your concern actually. So the patient is a 45-year female, and the previous medication she is on the glyclazide modified release 60 milligram daily, the metformin extended release 1000 milligram daily, rosuvastatin 5 milligram once a day, and telmisartan 40 milligram once a day. And the treatment given is advised on lifestyle modification, and the Dapagliflozin 10 milligram was added daily. Glyclazide modified release 60 milligram was continued, and the metformin 1000 milligram also was continued. And follow up outcome at 3 months, the A1C has come down to 7.5, that is 1% reduction in the A1C, And the fasting plasma glucose has also reduced from by 20 points, that is 146 milligrams per deciliter, and the weight is reduced by 4 kilos, and they have not mentioned the BMI actually, and the blood pressure has also come down by 136 systolic and the 88 diastolic actually. So these are the benefits of this thing. What I said is there are not only reductions in the glycemic control, that is the glycemic triad, fasting, and the 2 hour post glucose and the HbA1c. It reduces the nocturnal blood pressure, also the morning blood pressure, and the afternoon and the evening blood pressure, that is round the clock blood pressure, especially the systolic. A considerable systolic reduction is there, somewhere around some 8 to 10 millimeters of mercury, with a less significant reductions in the diastolic, like that is 2 to 3 millimeters of mercury, and it reduces the weight. In my clinical practice, out of all I use, I have never used Dapagliflozin in my life. So I've used only the Dapagliflozin to start with, and later on Dapagliflozin when it is off patented. When I have seen thousands of my patients, the weight gain is so significant in the patients who are on this particular Dapagliflozin. Is very very significant. The 2-3 patients of mine have reduced by 15 to 20 kilos. All have reduced by 5 to 6 kilos. The very well motivated patients, where they meticulously adhere to the diet and the exercise and cessation of alcohol and the cessation of smoking, the weight reduction is very very significant. And coming to the Dapagliflozin and the clinical update. See, the comparative assessment of the long-term effectiveness and the safety of Dapagliflozin and Dapagliflozin as add-on therapy to hypoglycemic drugs in patients with type 2 diabetes mellitus. It's a 3-year retrospective observational study of 680 patients with type 2 diabetes mellitus. The inference is they have taken the multiple parameters like A1C, body weight, systolic, and the diastolic blood pressure, fasting, and the liver function, ALT, and the serum creatinine, and the EGFR, and the cholesterol, the triglycerides, and LDLC and HDLC. The Dapagliflozin and the Empagliflozin were comparable to lowering the blood glucose, body weight, the blood pressure, and the lipid parameters. The Dapagliflozin, the metabolic effect is like the Dapagliflozin 10 milligram daily for 6 months to obese patients with type 2 diabetes mellitus without the established cardiovascular disease, and the inference is that statistically significant reductions in the HbA1c, fasting plasma glucose, LDLC, and the total cholesterol, body weight, and BMI, waist to hip ratio, body mass, body fat mass, and the aortic pulse wave velocity. The insights from this is the study done on this particular, the first study that rolled out with the Dapagliflozin is declared TB 58. So later on it has been studied very extensively and very thoroughly, like the landmark trials like DAPA-HF and the CKD. These are the 2 landmark trials after the declared TB 58, which has established the role of this particular Dapagliflozin in the heart failure and the chronic kidney disease actually. So I'll just briefly tell you the contraindications of this particular SGLT2 inhibitors. All the SGLT2s, like the first contraindication being the recurrent genitourinary tract infections and the vaginal the vulvitis or the vaginitis or the vulvovaginitis in females, the prostatitis or the balanitis or balanoposthitis, that is the recurrent fungal infections, that is Candida albicans. This is the first contraindication. And second thing is, it should not be used when the patient is dehydrated, because on top of it, it has got the SGLT2 inhibitors has got the osmotic diuretic effect, which leads to some loss of water fluid from the body. And if the patient is already on some diuretic for any other reason, maybe a part of hypertension or maybe part of the heart failure, maybe any reason that the patient is on loop diuretics or the MRAs, that is mineralocorticoid receptor antagonists, whether it is steroidal mineral MRAs or the non-steroidal MRAs like finerenone, the steroidal or the spironolactone and the eplerenone, you need to be very cautious. So the general dictum is, if the patient doesn't have the genitourinary tract infection or this particular the candidiasis, once the patient develops after using this particular, it's one of the side effects that the SGLT2 inhibitors, we see a little bit increased incidence of the genitourinary tract infections and the Candida albicans. And apart from that, per se, diabetes itself is the uncontrolled, the glycemia itself is the harboring agent for all these problems. But if you come across after the initiation of the SGLT2 inhibitors, the patient complains of that, you temporarily withhold this particular this SGLT2 inhibitor, and you can treat that particular cause, whether it is the UTI or the candidiasis. And once it is cured, and wait for 10 days or more, and if the patient is well and good, you can again restart the initiation of the reinitiation of SGLT2 inhibitors. But if it recurs again and again, that is called the recurrent GUTIs and the candidiasis, it is high time you need to stop this particular patients who are using SGLT2 inhibitors. You need to withdraw SGLT2 inhibitors once for all. So these are the contraindications. And the other contraindication is the type 1 diabetes. You should never use it. It's only the drug of choice for type 2 diabetes, though the European Union and the European Commission EC and the EU and the European Medical Agency EMA, they have started studying long ago, like from the last 4 years. They have been using this particular the Dapagliflozin and the Empagliflozin, and for some reasons sotagliflozin was stopped. They started using it for type 1 diabetes mellitus, very meticulously monitoring the cases, not letting them getting into this the DKAs. So the inference is that the insulin dose has come down drastically after combining this SGLT2 inhibitors, but that is pertain to only the European Union. So Americans, they have not tried, nor any other country has tried. So it is an absolute contraindication for us as Indians that SGLT2 should never be used in case of type 1 diabetes. So the use of SGLT2 inhibitor therapy is not recommended in these conditions. They are not recommended to improve glycemic control in patients with type 1 diabetes mellitus. It may increase the risk of decay in these patients. And not recommended to improve the glycemic control in patients with type 2 diabetes mellitus with an eGFR of less than 30 ml per minute per 1.73 meter square of the surface body area. That's what I told you earlier. And not recommended for the treatment of chronic kidney disease with the polycystic kidney disease. You have to bear it in mind. So they not recommended for the treatment of chronic kidney disease patients receiving high dose of immunosuppression, and not recommended during volume depleted state. That's what I said, the dehydrated state, and where there is the electrolyte imbalance and all. They assess renal function and the volume status and correct any volume depletion before initiating SGLT2A. You have to be very cautious. See, most of the times all the type 2 diabetes patients, not all those, 80 to 90% will be on either ACE inhibitor or ARBs, which may induce the hyperkalemia, or this particular diuretics, maybe the thiazide like diuretics like chlorthalidone, sorry, for hypertension, or for some other reason, maybe the pitting edema, what you see in this anemia, or the heart failure, or the hypoproteinemia, the loop diuretics, or the furosemide, or nowadays we are not using furosemide, we are going only for torsemide, and the another new molecule has come, that butyramide, or the mineralocorticoid receptor antagonist, that's what I said, the spironolactone or the eplerenone or the finerenone, you have to be very cautious as far as the electrolyte imbalance is concerned, because they cause some sort of electrolyte imbalance. All the molecules, what I said, they cause hyponatremia and the hypokalemia, whereas in contrary, the ACE inhibitors and the ARBs, these two should never be combined. Again and again, I tell in all my speaker programs, it's a crime if you combine ACE with ARB. It should not be combined at all. See, long ago, in around somewhere around in 2003 or 4, I remember, the one company has come out with this particular the combination of ACE inhibitors and ARBs, where I strongly raised my voice, and I had to file a case in the court of law to stop that irrational combination, because that leads to fulminant hyperkalemia, which may lead to the sudden kidney failure, and the patient dies miserably actually. So now remember always, either ACE inhibitor or ARBs, but never combine both. Not recommended during volume depleted state. Assess real function and volume status and correct by volume depletion before initiating the SGLT2 inhibitors. And without SGLT2 inhibitors, at least 3 days prior to any major surgery or procedures associated with prolonged fasting, resume SGLT2 inhibitors when the patient is clinically stable and started taking the oral intake. Contraindicated in patients with known hypertensive sensitivity to this medication, and withhold SGLT2 therapy in temporary clinical situations that could predispose the patients to ketoacidosis, and the precipitating conditions including the under insulinization due to insulin dose reduction or missed insulin doses, acute febrile illness, and the starvation and the ketogenic diet, surgery, volume depletion, and alcohol abuse, and especially the patients during pregnancy and even during the lactation. These are the ones should that's what the not recommended. The contraindications where this SGLT2 inhibitors should not be used actually. So let us have a glance about this particular, the effects of SGLT2 inhibition on the metabolism of this type 2 diabetes mellitus patients, the primary effects and the intermediate effects and the clinical effects. This is divided into 3 parts. And coming to the primary effects, the glycosuria, that is reductions in the fasting hyperglycemia, reductions in the postprandial hyperglycemia, increases in the 24 hours time in range. This is very important, TIR. They try to maintain the TIR, 24-hour TIR. Never it should be above the time in range, below the time in range, and increase the risk of genital infections. And the intermediate effects, they again divided into the metabolic modulation and the transport interactions. Metabolic modulations is the substrate switch, that is the fasting mimicry, and the reduction of our adiposity, the ketogenesis, improved mitochondrial efficiency, and the transport interactions are the transport natriuresis, decrease in the uric acid levels, and decrease in the renal energy requirement, and improved iron metabolism. One of the greatest advantages of these SGLT2 inhibitors, where the patients have got hyperuricemia or the frank gout, it reduces the uric acid levels, which is a plus point. But if it goes below the recommended level of uric acid, like somewhere it shows like 3 milligrams per deciliter, you should stop this particular deleterious effect of this hypouricemia actually. So the clinical effects, coming to that, the early clinical effects and the chronic risk modification. The early clinical effects is the reductions in the ectopic fat deposits and the increase in the insulin sensitivity, improvement in vascular dynamics, improvement in autonomic function. And the chronic risk modification is the decreased vascular complications in type 2 diabetes mellitus and the decreased risk of heart failure events, either the heart failure or the hospitalization for the heart failure, and slowing of the chronic kidney disease progression, and reductions in anemia because it improves the increases the erythropoietin, and the hypertension and sleep apnea and gout. So coming to the SGLT2 inhibition and effects on the cardiovascular pathophysiology, actually the SGLT2 inhibition leads the effects on the preload reduction and the afterload reduction and the effects on the myocardium. The preload reduction leads to increase in the free water clearance and the decrease in the stressed blood volume and the decrease in the pulmonary vascular pressures and decrease in the intraglomerular pressure. And coming to the afterload reductions, it increases the endothelial function, that is improves the endothelial sensitivity, which is a very major plus point for the protection of heart, and the decrease in the vascular stiffness, and the decrease in the neurohormonal stimulation and increase in the autonomic balance, and effects on the myocardium, especially increase in the metabolic efficiency, increase in the diastolic relaxation, increase in the oxygen demand supply balance, and decrease in the left ventricular hypertrophy, and decrease in the left ventricular remodeling and fibrosis, and also decrease in the left atrial remodeling also, which lead to the improved cardiac structure. So now coming to the next slide, that is insights from the Declare TIMI 58. I'm sorry, I'm suffering from severe URTI, cough and cold fever. And you can see on the left hand side the effects of dapagliflozin 10 milligram versus the placebo. Again, it is divided into the major adverse cardiovascular events and the cardiovascular disease and the hospitalization by the heart failure and the renal incidents. So you can clearly see all the points going down after the initiation of 10 milligram dapagliflozin. So the study included, that's what I said, the maximum number of study was included with dapagliflozin only, that is 17,000 change patients with type 2 diabetes mellitus, and 60% the primary prevention population with multiple cardiovascular risk factors, and 40% the secondary prevention population with established cardiovascular disease. So the results are the significant reductions in the MACE in patients with history of prior MI, the heart failure and the renal benefits observed across all the groups. So this slide shows the effects of dapagliflozin on hospitalization in people with type 2 diabetes mellitus, the post-hoc analysis of the Declare TIMI 58 trial, and the association of dapagliflozin treatment with the risk of first and total hospitalizations using different definitions. So the inference is dapagliflozin reduced the risk of the first and total non-elective hospitalization for any cause in people suffering from type 2 diabetes mellitus, regardless of the presence of atherosclerotic cardiovascular disease, including the hospitalizations not directly attributable to the cardiac and kidney or the metabolic causes. And dapagliflozin treatment is associated with reduction in the epicardial adipose tissue thickness and the epicardial glucose uptake in human type 2 diabetes patients. You can very clearly see the secondary outcomes of the DAPA heart trial actually. the epicardial adipose tissue versus placebo on the left hand side, the epicardial adipose tissue versus DAPA on the left hand side, which shows that the inference is the dapagliflozin showed a significant 19% reduction in the thickness of epicardial adipose tissue compared to the placebo group, which is statistically significant. The effects of dapagliflozin and the progression of atherosclerosis in type 2 diabetes, a meta-analysis actually. So you can see the busy slide shows all the parameters like HDLC and the flow mediated vasodilatation and the EGFR and the triglycerides and the EGFR, HbA1c, systolic blood pressure, diastolic blood pressure, body weight and waist circumference, where the difference is very significant as the p-value shows, like you can go through all the p-values, which are all the parameters are statistically very significant. And dapagliflozin has got a terrifically better influence over the HDLC and the FMD and the EGFR, and it concurrently had an advantage in controlling triglycerides, systolic blood pressure, the diastolic blood pressure, HbA1c, body weight and waist circumference. And cardiovascular outcomes between the dapagliflozin versus the empagliflozin in patients with type 2 diabetes mellitus. Time to event curves of the primary endpoints according to the types of SGLT2 inhibitors. A in the total population, B in the propensity score matched population. So you can clearly see the graphic representation, which is on the left hand side and right hand side, and the inference is no significant difference between dapagliflozin. They are equally efficacious, equally effective. Between the DAPA and the EMPA groups in the risk of MACE. Dapagliflozin and the new onset of type 2 diabetes in patients with CKD or HF. The pooled analysis of the DAPA CKD and DAPA HF trials. You can clearly see the difference, and the inference is the dapagliflozin reduced the incidence of new onset type 2 diabetes in participants with chronic kidney disease and the heart failure without a reduction in HbA1c. Of late, I need to add one more point. That's the latter I may forget about it. So earlier in the pre-diabetes, earlier we used to use only the metformin.
Network ఏం కట్ అయిపోతుంది సార్.
అవునా?
ఇప్పుడే సార్
ఇక్కడేం రాలేదు.
ఎస్ సార్.
మామూలుగా వస్తుంది నెట్వర్క్ కట్ అయితే.
అది
Yeah, sorry, there is a small technical glitch, please.
కొంచెం నెట్వర్క్ డిస్కనెక్ట్ అయింది సార్.
రీకనెక్ట్ చేద్దాం. మనం ఇది తీసుకున్నావా ఢిల్లీ?
తీసుకున్నాను సార్. డెల్తోనే కనెక్ట్ చేశాను సార్.
కనెక్ట్ అయితే జనరల్
ఇంతవరకు ఉన్నది సార్. ఇప్పుడే సార్ ఇంకా ఇప్పుడు కనెక్ట్ అయింది సార్.
This meeting is being recorded.
Yeah, Rajdeep, we are trying to sort out the technical glitch as the internet had some problem and it is restored actually. Happy to see you, Rajdeep.
Pleasure, my pleasure.
Yeah. Yeah.
Recording in progress.
Yeah.
Yeah.
Thank you so much for your patient listening, and the glitch is taken care. The dapagliflozin reduced the incidence of the new onset type 2 diabetes in participants with chronic kidney disease and heart failure without reductions in the HbA1c. The effects of dapagliflozin in patients with non-alcoholic fatty liver disease. That's what I used to say. Like now the terms are a little bit changed. The MASLD has come in place of the NAFLD and the NASH actually. So dapagliflozin effectively improves liver function parameters and the metabolic outcomes in NAFLD. Nothing wrong in using the terms NAFLD and NASH. So the latest term is MASLD, MASLD. The metabolically defective associated steatotic liver disease. So the mechanistic view on the effects of SGLT2 inhibitors on lipid metabolism in diabetes mellitus. And you can see the clinical evidence of the effects of the SGLT2 on the lipid metabolism. And the left hand side you can see the table, the lipid metabolism and the effects of SGLT2 inhibition, lipogenesis and lipolysis, and that induces lipolysis and inhibits lipogenesis, and lipid peroxidation and reduces the lipid peroxidation and oxidative damage, fatty acid beta oxidation, and it induces and promotes the free fatty acids oxidation and utilization, the cholesterol homeostasis, and it decreases the circulating cholesterol levels, the lipid absorption and the transport. It mobilizes the ingested stored lipids and diverts them from the adipose tissue. But on the whole, the only disadvantage with this SGLT2 inhibitors is so it increases the LDLC to some extent actually. So the company people will not highlight all these things, okay. But I am totally unbiased. Possible mechanisms on the right hand side, you can see the involved in the SGLT2 inhibitors dependent the lipid biogenesis. So SGLT2 inhibitors, they reduce the lipogenesis and induces lipolysis, and SGLT2 inhibitors they provide extra glycemic benefits by normalizing the lipid metabolism and preventing and improving the dyslipidemia. And dapagliflozin a promising treatment option for NAFLD actually. At week 24, the dapagliflozin group significantly reduced the LFC, which is statistically very significant, where the p-value is less than 0.001, and the compared to the control group actually. So the high certainty evidence on the definite therapeutic advantages in the NAFLD actually. Based on the high certainty evidence, the patients with NAFLD or the comorbid with the type 2 diabetes mellitus, dapagliflozin could lower the alanine aminotransferase as well as the body weight, waist circumference, blood pressure such as LDLC, and the glucose and the homeostasis model management, and you can see the improvement in the liver parameters in the lower table actually. Based on the moderate certainty evidence, dapagliflozin could modify the liver fat parameters. See, one thing I would like to tell you is no drug would be fruitful in the liver disease once once the fibrosis takes place actually. So that is once the pre-cirrhotic stage starts and it goes on to the cirrhotic stage, there is no the backward march at all. It is only at the level of NAFLD and NASH you need to evaluate further by this FIB4 score, and you can go refer to your gastroenterologist, medical gastroenterologist who has got a fibroscan. He'll give the extent of the disease where the liver is involved, and based on the liver function test, whether the patient is in the SGOT, SGPT and the alkaline phosphatase enzymes are elevated, which is called the transaminitis, that makes the lot of difference. Whether the patient is in the stage of transaminitis, the treatment is totally different, and in the case of non-transaminitis, they're totally different. But on the whole, the treatment is reduction in the weight is the cornerstone in the treatment of this particular NAFLD or this particular the NASH or the MASLD, MASLD. So the reduction of weight, the cessation of smoking, the cessation of alcohol, and a balanced nutritious diet and exercise. These are the means. And there are some the drugs, like so many drugs, they act in this particular chronic liver disease. Like you have got the pioglitazone used in the dose of at least 30 to 45 milligrams a day. The lower doses would not work out. The other scenario where we use this particular pioglitazone in type 2 diabetes mellitus. See, we say all the time it's the best insulin sensitizer. We say lower is more physiological, and I start with 7.5 milligram, and the maximum I use is 15 milligrams actually, because of the worsening of this particular the body weight and so whereas when it comes to the management of this liver disease, you have to start with the highest dose. The weight is not the parameter. Earlier we used to think that metformin is a wonderful drug for that, but now it is proven that metformin has got a very less role, and first drug of choice is pioglitazone, the insulin sensitizer, followed by metformin, followed by the SGLT2 inhibitors, and the GLP-1 receptor agonists, and the DPP-4 inhibitors, and the vitamin E, the 400 milligrams given twice a day for 3 months, and again you need to stop, because again it's a fat soluble vitamin. The hypervitaminosis E or D proves to be very, even the D also plays a very vital role. Even the statins or the fibrates or the PCSK9 inhibitors or the saroglitazar, it goes on like anything. The list doesn't end. It's a multi-pronged approach. On the one hand, weight reduction, and what I said, all the five principles: diet, exercise, reduction of weight, cessation of smoking, cessation of alcohol, and the drugs. It's a multi-pronged approach to treat that. Or else, the patient will end up in the pre-cirrhotic stage, which eventually has got a forward march by leading the patient to cirrhosis, and later on the stage is hepatocellular carcinoma, which is like very lethal and takes the life of the patient. So based on the moderate certainty evidence, dapagliflozin could modify the lipid parameters. And clinical update in India actually. So I am going little bit fast because of two reasons. The Reddy Labs, they asked me to talk about the role of dapagliflozin in heart failure actually. Today only they asked me to talk about this particular role of dapagliflozin in heart failure. And when I just came into my chamber, I was shocked to see the presentation. It was the role of dapagliflozin in the cardio metabolic continuum actually. So, and it has got lot of slides, more than 40 slides. So I am rushing up. It's already been more than 1 hour. And dapagliflozin showed a significant improvement in glycemic parameters, body mass index and BP when added to metformin in real world scenario. You can clearly see this change in the HbA1c, change in the body weight, change in the BMI, and the change in the SBP and the change in the DBP, which are the very beneficial actually. And efficacy in reducing the uric acid levels, that's we discussed it already. It is very helpful in hyperuricemia and the patient suffering from the frank gout. The rationale of combining SGLT2 inhibitors and DP4 inhibitors. The meta-analysis including 8 RCTs comparing the SGLT2 inhibitors and the DP4 inhibitors and the DP4 inhibitors, and 5 RCTs comparing SGLT2 bar, DP4 and the SGLT2I, with 3 RCTs involving both the comparisons. The First point is like SGLT2 bar DP4 inhibitors result in a greater mean A1C reduction than monotherapy. It's a common sense point actually. So you combine any two drugs, it has got a very good action. Like okay, you combine SGLT2 with metformin, or you combine metformin with the DP4 inhibitors according to the verified trial actually. So the longevity and the efficacy of metformin increases from 3 years to 6 years. I was one of the principal investigators of the verified trial, which we presented it in the EASD, the scientific sessions, September 2019. And afterwards, the corona came and all were virtual only. And significant differences in the body weight loss from baseline were observed only with the SGLT2 bar DP4 versus DP4 but not versus SGLT2I. The risk of hypoglycemic events were low and the similar between the treatment groups. So all the advantages of the metformin or the DP4 inhibitors or the SGLT2 inhibitors are they reduce the glycemic triad, the fasting and the post lunch and the HbA1c without letting the patient getting into the hypoglycemias. That is the greatest advantage of this because they are all acting on the extra pancreatic sites. They never act on the pancreatic site actually. They are not acting on the beta cells unlike the sulfonylureas. That is the reason whenever you are using this particularly, you are adding the SGLT inhibitors to the patient who is already on metformin and a DP4 inhibitor, and you are planning to already the patient is on sulfonylurea and you want to initiate insulin. Either you have to reduce the dose of insulin or you have to take off the sulfonylurea as the addition of SGLT2 inhibitor or addition of the insulin is going to have the incidence of a greater incidence of hypoglycemia because of the powerful reductions of the A1C by 1 to 1.5% with this SGLT2 inhibitors. So that lets the patient get into the hypoglycemias when the patient is on sulfonylurea and insulin. You have to be very, very cautious. Take off sulfonylurea and stay with insulin, that to start with the lowest dose and slowly increment according to the blood glucose levels. The combination therapy with the SGLT2 inhibitors and DP4 inhibitors is safe and that leads to a marked additional glucose lowering effect. The one thing I have observed is when you combine this particular the SGLT2 inhibitor with a DPP4 inhibitor like linagliptin, actually per se the linagliptin, you find a reduced incidence of the genitourinary tract infections and the vaginal vulvovaginitis or the belanopascitis. That is the one advantage of adding the DP4 inhibitors to this particular. We don't need to discontinue the SGLT2 inhibitors because of the recurrent UTIs and the candidial moniliasis. And the clinical effectiveness and the Dapagliflozin and the sitagliptin FDC in real world scenario. See, and the fixed dose combinations of the triple drug, that is my favorite molecule is the combination of the 10 milligram of Dapagliflozin and 100 milligram of sitagliptin and 1000 milligram of sustained release of metformin has got wonderful triple FDC of Dapa, Sita, Met, ER tablets once daily was significantly better in achieving glycemic control versus dual combination once daily in patients with type 2 diabetes poorly controlled with metformin. Whenever you find a young or the newly diagnosed type 2 diabetes patient, this is the best combination as of now that is available in the market with the combination of metformin and the sitagliptin and the dapagliflozin. Triple drug has got a lot of benefits. Combined effects of the dapagliflozin and linagliptin FDC in comparison to linagliptin monotherapy. So the mean difference of A1C actually it reduces because DPP4 is inhibitors are the weakest the anti-hyperglycemic drugs are the oral anti-diabetic drugs. when compared to SGLT2 inhibitors. So naturally, when you combine both, the reductions in the A1C are more. It's a 30-week multi-center phase 3 double-blind, double-dummy parallel group study of once daily dapagliflozin, linagliptin FDC compared to linagliptin single therapy in 2 to the 32 patients with inadequately controlled type 2 diabetes and metformin. The study was conducted at 16 sites across India between August 2022 and April 2023. The test group, that is the dapagliflozin bar linagliptin, had double the number of patients experiencing a reduction in A1C to below 7% compared to the reference group, that is linagliptin monotherapy alone. And the SGLT2 inhibitors and the combination of DP4 inhibitors, what is the place in this particular therapy? Appropriate use of an SGLT2 bar DP4 FDC based on a glycemic factors. You can see this particular the management of type 2 diabetes initiate with lifestyle modification on the left hand side. In treatment naive patients where metformin is contraindicated, intolerance and HbA1c is more than 8. And one more thing is, you want to initiate SGLT to the patient at any point of the disease course, especially early in the part. The A1C is not at all, you don't worry about the A1C. Even the baseline A1C is 7. Then also you add this particular molecule to this the double combination of metformin and the DP4 inhibitors. Irrespective of the baseline A1C, you can add this particular point. The only point I said is, if the patient is already on a sulfonylurea and metformin or DP4 inhibitor, and you are planning to introduce the SGLT2 inhibitors, or the patient is on SGLT2 inhibitor, you want to introduce either this particular the insulin. Actually, you have to be very very cautious with hypoglycemia, because the SGLT2 inhibitor being the potent the glucose lowering agent that lets down the patient with the hypoglycemia. So reduce the dose of insulin. The initial insulin should be start low, go slow, and slowly increment according to the blood glucose levels. So in treatment naive with metformin patients, in combination with metformin, the way the patient's baseline of HbA1c is high, 9%. And above 9, according to the American Diabetes Association recommendations, say the 24, whatever it may be, you have to use insulin along with the existing OADs. Uncontrolled on metformin monotherapy, in patients uncontrolled on metformin with A1C of around more than 8.5%. And on the right hand side, management of type 2 diabetes, uncontrolled on metformin plus second line. The uncontrolled on metformin and DPP4 or SGLT2 inhibitor, and the other condition is the uncontrolled on metformin and second line agents except DPP4 bar SGLT2 inhibitor combination, and insulin plus other agents add on to insulin. The combination may be used as an add-on to insulin with an individualized approach and ensuring the appropriate titration of the insulin. See, the greatest advantage of the metformin and the DP4 inhibitors and the SGLT2 inhibitors, they can be used with any other. They go well with pioglitazone, they go well with insulin. But only the thing I would like to remind you is, never combine the patient who is on the pioglitazone. The insulin and pioglitazone should never be combined. It's a mandate that you should never combine, because the insulin sensitizer effect and the weight gain because of this particular the insulin and the pioglitazone may result in the volume overloaded state. So the only contraindication is that the pioglitazone and insulin should never be combined, like AC and ARB. And the guidance for initiation of the triple drug, the SGLT2 plus DP4 inhibitor FDC based on the the promoting weight loss. So the combination may be preferred over the conventional therapies to promote weight loss with no increased risk of hypoglycemia and type 2 diabetes management. The guidance of the initiation of SGLT2 plus the DP4 inhibitor FDC based on the cardiovascular risk, including heart failure. See, this is the one condition wherein this is very very effective. That is the heart failure actually. The SGLT2 role of SGLT2 inhibitor in the reducing the incidence of decreasing the mortality in the patients suffering from heart failure and decreasing the incidence of hospitalization for heart failure, because the Indian scenario, it is pathetic. Of the 90% of the Indian patients, they do suffer from where there is diabetes. They do have these multiple risk factors which lead to heart failure, but taken for granted, heart failure, you consider it as a very severe insulin resistant state. Heart failure is always an insulin resistant state. So that too, the HREF is 90% among the heart failure. Only 10% is HPF or the heart failure with mildly reduced ejection fraction. There are three terminology, like heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. In between there is less than 40 of left ventricular ejection fraction, we call it HRF, and anything above 60% of LVF, we call it excellent, normal, and anything from 50 to 59 is called this particular the 41 to 49 is called the heart failure with mildly reduced ejection fraction, and 50 to 59 is called the HPF, that is heart failure with preserved ejection fraction. Like EGFR, you remember 60, that holds good for left ventricular ejection fraction as well as the CKD also, the EGFR. If the EGFR is above 60, it's well and good. So though theoretically they say above 120 is normal, nobody has 120 of this particular EGFR. And likewise, I have never seen any patient who has got 100% of left ventricular ejection fraction. Maximum I have seen is 80%. Yesterday only I have seen, I was fortunate to see that the cardiologist has given that the LVF is 75% to 80%. So Dapagliflozin, what the future holds. I have told you the landmark trial that started with the Declare TB 58 study, and the landmark trial is DAPA Heart and DAPA HF and the DAPA CKD. The Dapagliflozin pipeline studies, these are all the studies which are in the pipeline, yet to come in the future. We are waiting for that. And now coming to the last slide, the take home message, the essence of it, SGLT2 inhibitor is preferred in type 2 diabetes associated with heart failure, CKD and obesity. And Dapagliflozin has proven its metabolic benefits apart from the cardiovascular and renal benefits. And also it has got a very good proven role in the hepatic scenario, liver scenario, what we have mentioned, and then the hyperuricemia also. And the metabolic benefits of Dapagliflozin makes it suitable for type 2 diabetes patients with Asian Indian phenotype. And thank you for your patient listening.